Hello, and thank you for joining our Morning Commute podcast series on multiple sclerosis. Morning Commute is developed in collaboration with At Point of Care and Projects in Knowledge and is part of a continuing medical education series. This CME-CE activity is supported by an educational grant from Biogen, Bristol Myers Squibb, and Sanofi Genzyme. Information about the faculty and disclosures can be found at morningcommutepodcast.com/MS4. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. You can also find the complete 6-part series by visiting morningcommutepodcast.com/MS. In this episode, Close to the Mark on Secondary Progressive MS, our faculty will discuss the current evidence for disease-modifying therapies, DMTs, in patients with active secondary progressive MS. How is SPMS diagnosed and how does it differ from relapsing remitting MS? Moreover, are the treatments for SPMS effective for RRMS? I'm your host, Candace Hoffman, Managing Editor of Morning Commute. We are joined by Dr. Fred Lublin, who is the Saunders Family Professor of Neurology and Director of the Corinne Goldsmith Dickinson Center for Multiple Sclerosis at Mount Sinai Medical Center in New York City, and by Dr. Robert Bermel, a neurologist in the Neurological Institute's Mellon Center for Multiple Sclerosis at the Cleveland Clinic in Ohio. Dr. Lublin will begin our discussion.
Welcome to this podcast, Close to the Mark on Secondary Progressive MS. I'm joined by my friend and colleague from Cleveland Clinic, Dr. Rob Bermel. Welcome, Rob.
Oh, thanks, Fred. It's great to talk to you today.
So we're going to talk a bit about secondary progressive MS, and we need to have this conversation because there's been some confusion around it. There's always concern because it's the form of MS where individuals develop the most disability, along with primary progressive MS. But progressive forms of MS are the form of MS that we're looking to avoid in patients. And the other, as we'll get into, is our therapies are less robust and much more limited for treating progressive MS. But first, the secondary progressive MS presents some very specific challenges. And the first challenge of it is diagnosing it. So the standard diagnosis of secondary progressive MS is an individual who starts out with a relapsing MS course and then transitions to a point where there's gradual worsening, independent of relapses, over time. And so it's a clinical diagnosis. And there may be superimposed relapses on top of that progressive course. But the major differentiation is that in between those relapses, they're gradually worsening. And as we're going to discuss here, it has to be distinguished from worsening MS due to stepwise accrual of disability from relapses that don't completely recover. And since over 50% of relapses don't completely recover, that stepwise worsening is an important factor, especially early in the course of disease. But no matter how bad someone gets with stepwise worsening, that's not progressive MS. Progressive MS only occurs when there's the gradual worsening over time. And the other part of this that one has to remember is that progressive MS is not inexorable, that it can plateau, it can fluctuate a bit, it can even stay stable for a long period of time, and sometimes forever. And so that sometimes complicates people's understanding as well. And so when we put out the phenotype papers in 1996 and again in the 2013 revisions, we recognized really two different progressive forms of MS, primary progressive and secondary progressive. Primary progressive, they start out with gradual worsening without having any history of relapse activity, although they may, in time, have superimposed relapses. Whereas secondary progressive MS can only occur in someone who starts out with a relapsing form. And so we put those out, and we're going to talk a little bit about that, and we'll a little bit more of this, and then we'll get into how we subtype them as well. But Rob, why don't you talk to us a little bit about the idea of MS as a continuum?
Sure. So I think, Fred, you bring up this really important idea of the disease phenotypes. And when we talk about these things, I think that what's happening in the back of all MS neurologists' mind is that when you talk about the distinction between secondary progression or disability that's accrued due to secondary progression versus disability that's accrued residual to relapses, I think that triggers in all of our minds pathophysiologies. In other words, thinking about different processes that are happening in that patient. Because when you have a patient who's early on in MS and they've experienced a few relapses in, maybe even a number of months, and they have residual disability that they didn't recover from those relapses, personally, I think of a different set of pathophysiologies, a different set of interventions than the person who has pure superimposed progression in the background. And so, in my mind, really, the mechanisms, of course, are heterogeneous. They're not completely elucidated, but I tend to think more in the early, patient with multiple relapses and incomplete recovery of in inflammation, maybe more direct immune-mediated injury, related to enhancing lesions, related to breakdown of the blood-brain barrier, acute inflammatory focal events. And then that person who has more superimposed progression, I tend to think of as having, even more poorly described pathophysiology, but, to sum it up, sort of maybe more degenerative mechanisms without so much active inflammation. You mentioned, Fred, how this is a clinical diagnosis, and I'll tell you that there's two ways in my clinic that secondary progressive MS often rears its head and becomes pretty obvious. One is in the patient where I say, think back to last year at this time. So say we're, around the holidays, maybe say, well, think back to last Thanksgiving. What were there things that you were able to do then that you're not able to do now? And they say, well, I could walk the airport 15 gates, no problem, last Thanksgiving. And I could never do that now. I need a cane, or I need to stop and rest every couple of gates. And I'll say, as a follow-up question, when did that happen to you? And they'll say, gosh, I didn't even know that. I couldn't tell you when it happened. It creeps up on people. It happens slowly. Whereas the patient who has had a relapse would say, well, that happened in March. I was in the hospital for 3 days, or in March, I was doing fine. And then all of a sudden the next week I was having this new symptom, leg weakness. So that question tends to think back to a year ago, where the things that you're able to do then that you can't do now tends to bring it out. The other situation where I've seen it come up is where I walk into a room and tell a patient, good news. Your brain MRI looks completely stable. There's no new lesions. And they look at me kind of quizzically and they say, well, then why am I doing so much worse? And they've had this slow, the patient's there to discuss this kind of slow worsening of things and how they've maybe reached a functional threshold where now they're not able to do as much as they wanted to. And then I, as the doctor who am there to, talk about their test results, coming off as a little bit dissonant. And that's the other time where it really becomes obvious that, hey, we might be talking about progressive MS. But like you said, it does not mean, for instance, that the patient's walking with a rollator or a walker or a cane necessarily. It's really that progression that happens over time. If you measure it in your clinic, so if you measure things like 25-foot walk or a 9-hole peg test or other neuroperformance measures, you may be able to identify progressive MS sooner than you could identify it just asking those questions. But even then, it's tough to pick up on it in real time. It's much easier to identify it in retrospect when you look back at the curves that you plot of those time 25-foot walks over the years. Say, oh, geez, I guess maybe this person's been progressing for the last couple of years, and we didn't notice it visit by visit. And that's the way it happens. It sort of creeps in. But those heterogeneous mechanisms, I think, that's when I think of MS as a continuum. I think of patients being able to have both of those. You can have relapses and superimposed progression. or you can have more of one or more of the other. And I think, in my mind, at least, it triggers the underlying pathophysiology. And even though we don't know, we don't have worked out yet the specific immunopathology or the degenerative pathology of each of those components, I still think it's a useful framework to think about relapses and progression as probably somewhat different processes in patients, and being able to sort them out.
Yeah, I agree with you on the dichotomization. I worry that's an oversimplification. And the pathologists do tell us that there's inflammation along the course of MS from start to finish, including in the burned out brains. But certainly there's degeneration going on. And I think that the fact that we don't do very well in treating it confirms that. There is this diagnostic issue of progressive MS. First of all, doctors hesitate to do it because it scares patients. Even early on, and you've had this experience, I'm sure patient comes in with their first attack and they degrade, and say, do I have progressive MS? Because they look online somewhere and they see that this is, a less favorable form of the disease. And so I think doctors are reticent to apply the label because it is clinical. And I understand that as well. And also there's people who are reticent to apply the label because it may affect their insurance coverage for medications. But there is this period of uncertainty as to when someone is truly transitioned into secondary progressive MS. And my colleague, Alana Katz-Sand, published what is a seminal paper on this, just looking at Aaron Miller's patients over time, and looking to when the phenotype was said, oh, this actually is secondary progressive MS. And it took almost 3 years of thinking about it before there was this certainty. And so for us, I think we need to think about how better we can approach this, because one of the things we've learned during this treatment era is the earlier we treat any form of MS, the better individuals do. They just early treatment has a much better efficacy mark. And that goes for progressive disease as well, probably. And their secondary progressive MS is a challenge because the patients have to get through a relapse and remitting phase first before we diagnose them as secondary progressive. So when you look at the clinical trials of secondary progressive MS, they've had the longest duration of disease of any of our therapies, whereas the relapse and remitting and even the primary progressives all have a much shorter duration of disease when they enter the clinical trials. So this uncertainty in diagnosis is something that we need to think about in the future in terms of finding a marker, maybe a biomarker of progressive disease. And I don't know that it exists now. There are some MRI changes, paramagnetic rims, and slowly expanding lesions that are more common in progressive disease, but not unique to it. There's some work being done on cortical lesions as well, but I think we're going to be able to diagnose this sooner.
Distinguishing secondary progressive MS from relapsing remitting MS, Drs. Lublin and Bermel delve further into the subject of potential biomarkers. But are they ready for prime-time clinic use yet, or is there a potential for misclassification or misdiagnosis? Let's rejoin our discussion.
Yeah, I think if we did have a diagnostic biomarker for secondary progressive MS, that would really help. I think in many patients, not so much a switch or an abrupt change as it is a gradual evolution into secondary progressive MS, but if we could start to pick up some of those markers, you mentioned slowly expanding lesions or paramagnetic rims, I think those are both potentially promising, but still relegated to the research realm right now. Also, hallmarks like microglial activation that's able to pick up on certain PET tracers might help us to understand the pathophysiology. Maybe neurofilament light as a blood biomarker may help us to understand patients who are undergoing neurodegeneration, even in the absence of acute inflammation measured by gadolinium-enhancing lesions or new T2 lesions. So I think there are some potential candidates there. But still, this is where the fun of being a neurologist comes in, right? Is we do not have all the answers. It still requires clinical judgment. and it still requires judicious application of the phenotype criteria that that you've been the lead on for the entirety of their evolution. And so I'm curious what you think about neurologists applying these phenotype criteria. What do they get right? What do they get wrong?
Well, I'm actually very concerned about misphenotyping as much as I am about misclassification at diagnosis. They have different implications. Misdiagnosis actually is more troublesome in terms of people getting started on a therapy they don't need. But for us to better understand secondary progressive MS, we have to be sure we're categorizing it correctly. And so I don't think, for example, there's any EDSS that defines secondary progressive MS. I think that there's no age, but age is a factor. And we're going to talk about age in terms of treatment, but age is also a factor in terms of progressive MS because it occurs in an older age group. But I think that until we have a better way of diagnosing it, we're not going to understand how best to approach it. And we'll talk a little bit more about active and non-active progressive MS towards the end of this, because there's problems there too. But my main concern is this confusing worsening, which could happen either by progression or by stepwise accrual of disability for secondary progressive MS. And because of that, and because it's a clinical diagnosis, that all of our prognostic indicators and even the biomarkers are hard to understand because we don't know what the gold standard was for diagnosing secondary progressive MS. But we have made some inroads into treatment of progressive MS. And I think that it's worth reviewing some of that, and also how we approach the treatment. And you've got some ideas and discussion about age in terms of treatment with disease-modifying therapies.
Remember to visit morningcommutepodcast.com/MS4 to claim your credits and evaluate this program. Doctors Lublin and Bermel now turn to treatment options for secondary progressive MS. Let's listen in.
Yeah, no, I think that when I think about treating secondary progressive MS, I think of two primary risks. One is missing out on an opportunity to treat someone who might potentially benefit. And the opposite risk then, over-treating someone or treating someone with a medication that may cause safety issues or potentially side effects when they're less likely to benefit. And so personally, what I like to try to do is identify some factors in a given patient that would make me more inclined to treat them or think that they're more likely to benefit from a treatment versus somebody who they're less likely to benefit, but they're still accruing the same risk of side effects and of complications. And so I try to identify some core values there. Age is one of those. And so if, I don't really have a threshold per se, but if someone is much younger, then I tend to lean towards giving them every possible consideration of treatment. And if someone is older, then thinking about, well, geez, are they more on the side effects and complications from therapy end of things? And my experience in this is maybe a little bit from the era of the platform therapies where we had patients with secondary progressive MS where they were getting slowly worse year by year, still on interferon therapy and experiencing a lot of spasticity and maybe even things like depression as complications of their MS, and potentially a therapy could even worsen those. And so I'm always mindful of patients later on in their disease course, decades and decades into MS, of making sure that the treatment is giving them benefit and not causing them side effects and harm. So that's at the far end of that spectrum. But on the young end of the age spectrum, really, I think that patients deserve the benefit of potential treatment, even if they do not have a lot of disease activity. I'll say that besides age, disease activity is the other major criterion that I use. So if a patient has had evidence of disease activity, which I would call relapses or new MRI lesions or a gadolinium enhancing lesion, if we've caught one of those, in the last few years, I will certainly think that treatment with MS disease modifying therapy is appropriate, and I'll actually advocate for it in those patients. But I believe that there is a big gray zone in the middle here between patients at the older end of the MS age spectrum, so say patients over age 60, 65 with progressive MS and no evidence of disease activity in many, many, many years, versus patients who are very young at the beginning of their journey with MS. And even if they do have progression, that is slow worsening of their disability over time in the absence of relapses, that I'll be more likely to treat them. And a lot of those principles derive from some of the clinical trials that we've seen with therapies in progressive MS dating all the way back to the trial that Jeff Cohen ran years ago with interferon, the IMPACT trial, which showed some benefit in patients' upper extremity function if they were younger age in particular, or had recent evidence of disease activity, but I think have been consistent even through our more highly effective therapy trials. But that's the way I tend to frame it. I don't know if that's similar or different from what you tend to do.
I think there are some data that's being looked at further that age is an important factor in DMT therapy, even for relapse and remitting disease, that the therapeutic effect may be less as individuals get older. We certainly know that inflammatory activity is less as individuals get older. Even the natural history of untreated MS shows that relapses and GAD-enhancing lesions go down over time, which highlighted the fact why you had to have control groups to do a study. So I think it is an important consideration. And I worry about this older age group who are still progressing. The ones you referred to, the over 60 or 65, because I worry a little more about the safety of the agent. On the other hand, they're progressing and you don't want them to lose function. They already have all the other comorbidities of old age that are affecting their function. And I don't have an answer. All I have is a worry that they concern me. It's one of those instances, almost paradoxically, when you're looking at a progressive patient, that you'll do a scan and say, I hope I see something new. I hope I see activity on here, because then I feel better about treating you, and also the likelihood that the treatment will work. So let's talk a little bit about the studies we do have for progressive disease, and where we've succeeded and where we've failed and what we've learned. So why don't you kick that off?
Great. I've mentioned some of the earliest studies, but even consistently through our more recent studies, trials of B-cell therapies and sphingosine-1 phosphate receptor modulators, as well as VLA4 inhibitors, we've seen these two criteria emerge as, if you look at patients as a whole, that is patients with primary progressive MS or secondary progressive MS, large group of patients enrolled in a clinical trial. I think that the result of this trial in terms of benefit on disability is usually sitting on a knife's edge, that it's typically based on what type of patients enroll in a trial, whether the trial as a whole is going to be positive or negative. And to the degree that the trial enrolls patients that are more active, that is, have more recent relapses, maybe somewhat younger age, maybe had a higher percentage of gadolinium enhancing lesions at baseline, that it's more likely to, a given agent is more likely to show an effect in that population. Or if what you do is take subgroups of patients from one of those trials, you'll find, I think, that patients who had more recent disease activity or a younger age are the ones who are more likely to benefit. The adverse events also, Fred, that give me pause. And so when you're talking about potent disease-modifying therapies such as B-cell depleting agents, you worry that patients who have a higher level of disability, patients who are in older age, are just by their nature more at risk for infections, even common infections like pneumonias or urinary tract infections, and that the sequelae of those infections might be more severe, that they might be more likely to land them in the hospital. And, the specter of malignancies also exists, and they're more common in patients over age 60. And so I think we do need to be judicious with our use in certain populations, but also I tend to agree with you. It sounds like that we do not have the pathophysiology of secondary progressive MS completely sorted. Far from it. And if I have a therapy, especially in a younger individual and someone with more recent disease activity that I think might have the potential to benefit them, even if it isn't going to be the cure for their disease, even if it would help somewhat to slow I would say, sort of think of it as the cumulative damage in the form of acute inflammatory attacks, relapses, new lesions, brain volume loss, disability level, of course, that I'm likely to use that agent in somebody if I don't believe that I'm likely to harm them. So that's how I use, kind of the integrate the pooled results of the clinical trials that we've had into my practice. Even though, as you can see, it's a lot of expert judgment in these circumstances as well.
Doctors Loveland and Bermel discussed two fairly recent trials that are showing promise as treatment options. The oratorial treatment of ocrelizumab versus placebo for primary progressive MS, and the EXPAND trial that looked at siponimod versus placebo for secondary progressive MS. Let's rejoin the discussion.
Okay, and your thoughts about the successful clinical trials that we've had? I guess we had two to mention. One would be oratorio, and the other would be EXPAND. Oratorio for primary progressive, EXPAND for secondary.
For sure. So I think that these criteria, or these two clinical trials, oratorio and primary progressive, and EXPAND and secondary progressive MS, certainly have led to, I think, broader use of these agents in patients with progressive MS. The benefit in terms of the quantitative benefit on the disease is still not what we would like to see. I wish it was a cure. I tell every patient that I see with secondary progressive MS that progressive MS is the part of MS where all of the big minds and the research dollars are going these days in terms of trying to figure this out. But in the meantime, until we get there, until we get to restorative therapies, regenerative therapies, remyelinating therapies, until we get to true therapies that can halt the progression of secondary progressive MS, we do use the agents that we have, even if their benefit is subtotal. And I think the elephant in the room that I'd love to ask you about, Fred, is this idea that the FDA, the regulators, appear to have taken on this nomenclature of active secondary progressive MS and applied it to many of the disease-modifying therapies, even if there's not clinical trial data in that specific population. And I'm curious to know what you think about that.
So I think the logic of saying that MS activity and for us in the field activity, we've defined this, we did this in 2013 with the phenotype scripts, that activity was either a relapse or a new or unequivocally enlarging T2 lesion or a gadolinium enhancing lesion. So activity was new, clinical, or MRI activity. And we proposed that so that we could get a dynamic picture of what's going on with the patient. And when we did that, we said that it had to be framed in time, right? You had to pick a time frame. Say the patient was active in the last 6 months. We said at a minimum, do that assessment every year. So I think the idea of saying that activity is activity wherever you are in the spectrum of MS is reasonable. I think that suggests that you should treat it with one of the anti-inflammatory agents, absent the evidence. And the evidence only exists in the siponimod trial, right? There really aren't any other studies that clearly show an effect on secondary progressive disease in patients who have activity. But I'm actually okay with that distinction. And I would even propose it into primary progressive MS with activity. If they're having relapses, I would view it the same way. Where they went wrong on this is several-fold, but the first big mistake was to label secondary progressive with activity or just active secondary progressive MS full stop without defining the time frame. And what we said, and we published a clarification in May of this year to our 2013 paper to try and explain this, that it has no meaning without a time frame. And so all secondary progressive MS is active MS if you don't specify a time frame, because they had to go through at a minimum a relapsing remitting period to get there, and that's activity. And I think that the other thing that the US regulators, the FDA, were only talking about relapses, whereas our definition of activity also included MRI. The European Medicinal Authority took into consideration relapses and MRI activity, but still forgot to or ignored the time framing. And so it's kind of good for clinicians because you can take a very broad definition of what active secondary progressive MS is. But for our purposes, as clinical researchers, we really want to have it defined, what's that activity period, and then look at therapies that have an effect on that, but also, more importantly, look at the non-active secondary progressive MS, because that's our big unmet need. So once we get past that confusion, and that confusion actually makes it a little more difficult to do the studies, we need to look at the patient who's progressing, either primary or secondary, independent of any relapse activity, and even better, absent any relapse activity. That's, I think, our major unmet need. What do you think?
Yeah, no, I agree. I think that measuring these things in clinic is definitely a challenge. We have a large MS center here, and I think of us as pretty well aligned as partners within our practice of the way we measure things, the way we document things, and still, it is a real challenge to year after year, if you're taking care of a patient with MS, or for instance, recently I had a colleague who retired and picking up some of his patients, trying to learn from the documentation what was a specific patient's history in terms of disease activity tends to get buried in the notes over time. So I think pulling some of that information through and being able to actually measure what the disease activity was, like you said, in the last year, in the last 2 years, would be really useful. I think there's some practical ways to do it. So we, for instance, ask our neuroradiologists to give us structured reports of MRI scans for patients with known MS that we're monitoring. So they actually have to stipulate for us how many new lesions there were compared to the last scan and what the date of that last scan was, how many enlarging lesions, how many gadolinium enhancing lesions. And that way we have a number to sort of put in that follows with a patient, and we can chart it over time to sort of look at the disease activity. You can measure things like neuroperformance tests to plot the patient's history in terms of walking speed or manual dexterity over time. But it becomes a challenge in clinical practice to identify at each time, now wait, when was this person's last disease activity, and would they benefit or would they not benefit from a DMT? But until we get medications that specifically attack those other mechanisms of action that underlie secondary progressive MS, I think the medications like you mentioned, siponimod, or a B-cell depleting therapy, which has some rationale for use in progressive MS based on the Oratorio trial, I think definitely have a place in the therapeutic armamentarium, even though they're imperfect and even though we're waiting for the next generation of therapies to emerge.
So there you have it. Our major unmet therapeutic need right now is the treatment of progressive disease. And so thank you for listening to this Close to the Mark on secondary progressive MS. Thanks to our listeners. Thanks to Dr. Rob Bermel from Cleveland Clinic.
Thank you, Dr. Loveland.
And thank you for joining us today. Remember to visit morningcommutepodcast.com/MS4 to receive your credit and evaluate this program. In our next podcast in this series, Dr. Patricia Coyle and Dr. John Rinker will return to discuss S1P receptor modulators. That podcast, comparing notes on S1P receptor modulators, can be found at morningcommutepodcast.com/MS5. And you can find all of the podcasts in the 6-part series at morningcommutepodcast.com/MS.